Asians have a high risk of CBD and diabetes. Professor Prabhakaran is a cardiologist and epidemiologist by training. He is an internationally renowned researcher and is currently the Vice President, Research and Policy, Public Health Foundation of India, Executive Director of Center for Chronic Disease Control, New Delhi, India, and Professor in Tropical Medicine, UK. His work spans from mechanistic research to understand the cause for increased propensity of cardiovascular disease among Indians to developing solutions for CVD through translational research and human resource development. And this topic is very imminent and very important to our part. So I request Professor, please, any choice for your topic. Thank you.
Good morning, everyone, and first of all, thank you to Dr. Dhimal for inviting me to give this talk. It's always a privilege to be here in Kathmandu, and very, very grateful for this honor of giving this talk. It's a little bit of an outlier for this session because I believe this session was on health equity, but this is also important in terms of understanding the mechanisms of why South Asians have a high propensity to cardiovascular disease and diabetes. Now what I am going to do is, there are several things, several reasons that includes broad societal reasons. Second, individual vulnerability because of biological reasons. Third is environmental reasons, and of course we have the health system, policy issues, and several others. Due to paucity of time, I am not going to talk about all of those, but I am going to touch upon three things. The broad societal regions as to why the cardiovascular disease burden is increasing in this part of the world. And second, we'll look at some of the ethnic factors in terms of why we have high propensity to diabetes or other lipid abnormalities. And thirdly, we will look at some of the environmental causes in brief. So, precisely 65 years back, the first publication on the high burden of cardiovascular disease amongst Indians was published in the American Heart Journal by a group in Singapore. Now what they did was they looked at autopsy specimens of people who had died and looked at their heart. And what they found was that amongst Indian males aged between 30 to 39 and 40 to 49, there was virtually almost a 7-fold higher burden of coronary artery disease. This came as a big surprise because these people were hardworking, they were thin, they were not obese, risk factors, they were not smokers. So it was not very well understood as to why South Asians had a high burden of coronary artery disease. It was very clear. They compared to Chinese origin people, they compared, then there were several other studies across the world, including from UK, from South Africa, from Jamaica, and several other places. And what they said was that conventional risk factors like diabetes, hypertension, smoking, obesity does not fully explain why the cardiovascular disease burden is high among South Asians. And there were a wave of migrant studies, particularly in UK, Paul McKeegan and his group, and several others across the world, which showed that clearly that there was a high burden of cardiovascular disease amongst South Asians. Then in 2004, the InterHeart study was published, which was a large case control study of conducted in 52 countries, 14,000 cases of incident myocardial infarction, and 14,000 controls were compared. And they said across the world, irrespective of ethnicity, 90% of the coronary artery disease risk can be explained by 9 simple risk factors. They called this the population attributable risk, which means if I have a magic wand today and I eliminate all of these or improve some of these, then I can eliminate 90% of the coronary artery disease. So this was a very powerful study which said There is no difference in the ethnic groups. But when we looked at the analysis, particularly for South Asians, which was published in JAMA in 2007, the risk factors appeared to be similar, but the thresholds at which they were operating were very different. Our people were not obese, they were thin. They were relatively thin, compared to what we have in the Western population or other populations. That's one example, but there are multiple other differences which was not accounted for in this big study. The second thing which was observed was in the PURE study, which is a large cohort study across several countries, I think 52 countries again, and it has a population size of 200,000, very powerful study. What it showed was that the risk factor burden amongst the low middle income countries and low income countries, which was mostly from India and Pakistan in this particular study, showed that despite the low burden of risk factors, the mortality rates were higher. And this, they explained it based on the health system, the care-seeking behavior, which we heard a little bit earlier, and because of this, it was high. But is this a complete explanation? I particularly don't think so. So we need to explain this paradox that we have high mortality, low burden of risk factors. What could be the reasons? And I think there are four important reasons. One is the epidemiological transition, which I'll explain in a little bit, and socioeconomic status. Second is ethnic variations, particularly high propensity for diabetes among South Asians, new risk factors such as air pollution, and others such as variations in the health system, which I'm not going to talk about today. Now, what is epidemiological transition? Epidemiological transition refers to a change in the pattern of disease in a country away from infectious diseases to degenerative diseases. If you look at mankind, there have been two major transitions that has happened through the centuries. The initial transition happened when man who was human beings who were hunter-gatherers became agriculturists. And at that point of time, because they came into contact with the soil, they had more of infectious diseases. And we all know about these infectious diseases, pandemics, the plagues in the biblical period, then in the Middle Ages, cholera epidemic and other things which wiped out populations. This was called as the stage of pestilence and famine. Then as the agriculturists settled down, we got into a stage of receding pandemics. The pandemics started coming down, but still there were big epidemics of these diseases. Then during the Industrial Revolution in the 17th century, we started having, because we became more mechanized, we started becoming more efficient in terms of our labor force and other things, we started having man-made diseases such as coronary artery disease and others. And this is called degenerative and man-made diseases. And in stage 4, which many of the Western countries are because of policy changes and several other advances in treatment, you have a reduction in cardiovascular disease. Most countries go through this phase, but the fundamental difference is in the United States, UK and Europe, it took 200 years from going from stage 2 to stage 4, stage 2 to stage 3. In India, Nepal, Bangladesh, Pakistan, Sri Lanka and others, it's just taken 40 to 50 years to get to this stage. And we'll come to that a little bit later. Now people have added one more stage. In the US, as we have noted, there's high burden of obesity. I think the slides disappeared. High burden of obesity, and also because of some of the social upheavals, wars, there have been high mortality and there have been differences in terms of this disease pattern. So in terms of the process, countries move from less developed to developed countries, from an agrarian society, agricultural society to an industrialized society, from a pre-modern society to a modern society, and the healthcare pattern also changes. We saw that lady in the previous talk who was taking modern medicine as well as homeopathy and other traditional systems of medicine. So we move from primitive care to modern healthcare, and that's what happens. Now, how does this epidemiological transition affect cardiovascular diseases? In the stage 1, we have a life expectancy of 35 years, which is not found in most places, maybe some place of sub-Saharan Africa, some places in India, some places in Nepal, very small communities where the life expectancy is extremely low. India and Nepal are mostly in stage 2 and stage 3, between 50 and 60 years, and so there's a high burden of cardiovascular disease. So in terms of cardiovascular disease pattern, in early stages of transition, we have rheumatic heart disease. And in Nepal, I believe rheumatic heart disease is still widely prevalent, but it is coming down. In India, it's come down in most of the southern states, in some of the western states of India, but it's still prevalent in some eastern parts of the country and northern parts of the country. So in stage 3, what happens is we move and to developing coronary artery disease, myocardial infarctions, and angina, but stroke actually starts appearing in stage 2 itself, in early stage. And when you look at the burden of stroke in Nepal, in the poorer sections of the society, we have mostly hemorrhagic stroke because of uncontrolled hypertension. But as we move along that trajectory of epidemiological transition, we have a high burden of ischemic stroke. And in stage 4, because of policy changes, we start seeing a reduction in coronary artery disease. As we move along the path of this epidemic, initially coronary artery disease affects the richer people. And as we develop further, it starts affecting the poorer people. This is the natural history of the disease in the society. But the reason for this, and we are facing a problem in South Asia, is because we have had a very compressed transition, as I mentioned earlier, that it has happened within 50 years. The life expectancy of India and Nepal during independence was around 32 years. And it progressed to, right now, it is close to 70 years, give and take a little bit here and there, 65 to 70 years. In the US, to get from 30 years life expectancy to the life expectancy of 60 years or 65 years like what we have took almost 150 to 200 years. But for us, it has happened in a very compressed time frame. Because of that, we have double burden of disease. We have infectious diseases, communicable diseases. We have reproductive and child health diseases and non-communicable diseases. The determinants is because of rapid urbanization here, but it has happened in a chaotic fashion as compared to urbanization in the Western society. Limited to address this. So this is one of the reasons why the cardiovascular disease burden has been increasing. But this is not all the answer. The second one is we need to look at if there are differences of cardiovascular risk based on ethnicity. And I'm going to give two examples of diabetes and lipids. So let's take diabetes as an example. If we ask this audience, why is there a huge burden of diabetes in the world? All of us will say that globalization and urbanization has resulted in lifestyle change, which has resulted in overweight and obesity. Also, there is a genetic background because of which there is hyperinsulinemia, leading to insulin resistance, and ultimately leading to diabetes and impaired glucose tolerance. This is the general pathway of diabetes, and this is what most of us think. But when you do an ecological comparison, the first panel of the graph, of the table, this was published by WHO in 2012. At that particular point of time, overweight and obesity in the United States was 2/3 of the population. In China, it was 1/3 of the population. In India, it was only 13%. And Japan had 29%. But look at the diabetes prevalence. It's 9% in US, 9% in China, 9% in India. How do you explain this? If weight were to explain all the differences in diabetes, this doesn't explain it at all. So one might argue these ecological comparisons are not very good, the designs are bad, so we need to look at it a different way. So my colleague, Professor Venkat Narayan at Emory University, and one of his PhD students looked at what is the burden of diabetes in relation to weight amongst the various ethnicities, because US is a good place to do the comparison. You can get different ethnicities. So look at this particular figure and look at that red line. For South Asians or Indians living in the United States, diabetes levels, even within the normal body weight range, was higher, much higher than diabetes prevalence amongst the European and the African American population when they had reached the obesity or overweight level. So clearly we need some other explanation. So weight is not the only explanation for the reason for the high burden of obesity. So we thought, what are the potential reasons for this heterogeneity in the epidemiology of diabetes among different ethnicities? Is it reduced beta cell mass? Do we have smaller number of islet cells in the pancreas? Could be. Is it altered body composition? There have been multitude of studies across the world which shows that South Asians have higher body fat for every given body weight. Is it poor maternal and early childhood nutrition? There are evidences to suggest that poor maternal nutrition increases the risk of adult cardiovascular disease. Is it related to high carbohydrate diet? We all see that we all eat very high carbohydrates. Is it lipotoxicity because of the high fat content? Is it altered microbiomes? Is there endocrine disruption because of air pollution and organic pollutants? Or do the high prevalence of hepatic infection and non-alcoholic fatty liver disease increase the risk of diabetes with cellular level insulin resistance, increasing hepatic glucose output? And there are some other causes. So I'm going to explore two reasons. One, what we did was we have a cohort called the CARS cohort in Delhi and Chennai. So the Chennai population at that time had a full complement of oral glucose tolerance test. So we had data from Pima Indians in the United States, and we did a comparison of Pima Indians to Asian Indians in Chennai. The prevalence of diabetes was similar in both the population, 50% at 55 years. But look at the obesity profile. Pima Indians are supposed to be the best exemplars of diabetes in the world. They were very obese. The BMI was 33.7 and waist circumference 108. The Chennai Indians, the Chennai population was relatively thinner, BMI of 25 and waist circumference of 83. Look at the glucose profile. The Pima Indians had higher post-load 2-hour plasma glucose, and Asian Indians had higher fasting plasma glucose. Clinicians who manage patients of diabetes always find it difficult to control the fasting blood sugar. And irrespective, I mean, we give multiple drugs, despite that we have a problem in controlling the fasting blood sugar. Then if you look at the pre-diabetes distribution, a large majority of Pima Indians had impaired glucose tolerance, whereas Asian Indians have impaired fasting glucose. So insulin resistance is very high in Pima Indians, but insulin secretion is low in the South Asian population. So this is a possible explanation as to why thin people like us have more diabetes as compared to the Western population. So this is graphic representation of the Pima Indian and an Asian Indian. You look at the insulin levels at all stages, even at the normal glucose tolerance test, normal glucose levels, impaired fasting glucose, impaired glucose tolerance, at all levels, insulin levels are low in the Asian population. So the hypothesis now is that we have a narrow beta cell capacity. In the basal metabolic state, we have high fasting glucose. Slight or moderate, we increase our intake. We have little bit extra meals. The insulin levels, the beta cell gets very strained in terms of secreting insulin. And the dominant form of prediabetes is impaired fasting glucose. And there is a rapid conversion. In fact, the fastest conversion from prediabetes to diabetes is amongst the South Asians. Whereas other populations have wide beta cell capacity. Their basal metabolic state, the fasting glucose levels are low, but slight or moderate demands for insulin are managed efficiently over time through compensatory insulin secretion, and the dominant form of prediabetes is impaired glucose tolerance. And this slower conversion until obesity and insulin resistance are great. So this is one explanation, and I think moving forward in the next few years, we will have a new classification of diabetes, type 2 diabetes, into type 2A and type 2B. Type 2A is the regular form, and type 2B could be the one which we have. So because this is very important for us to understand, because the treatments will differ. The second thing is, this is the map drawn on the basis of low birth weight and underfine nutrition. Look at South Asia here. It's massive. It is almost half the world's map if we use low birth weight. But at the same time, the prevalence of diabetes is also very similar. How do we explain this low birth weight, childhood undernutrition, and high burden of diabetes? So David Barker from Southampton and Forstall from Norway, it goes by the name Barker's hypothesis or Barker's Forstall hypothesis, who said that the markers of chronic diseases comes very early on, particularly because of maternal undernutrition. And several studies have shown the link. I'm not getting into the details due to paucity of time. But I just wanted to show an interesting anecdote. A case report was published way back in Lancet. It's called the YY paradox. This is Professor Yajnik from Pune, who was on the right side, and Professor Yutkin from UCL. Their BMI was 22.3. I don't know how it happened, but it was exactly similar. But look at their body fat content. The body fat of Yutkin was 9%, whereas it was 21% for Dr. Yajnik. And several studies have been done in the world, which again shows high body fat content among South Asian. So understanding diabetes in India and South Asia, there are various research questions. We need to look at beta cell function and capacity. We need to look at non-alcoholic fatty liver disease, understand other mechanisms of disease. Now I am coming to lipids. When we look at lipids in comparison to other ethnic groups, for any given level of total to LDL cholesterol, the total cholesterol to HDL cholesterol ratio is higher, and the small dense LDL fraction is high. So LDL is divided into three different forms, 1, 2, and 3. 1 is the large LDL particle, 2 is the intermediate, and 3 is small. And small studies have shown that South Asians have a high proportion of small dense LDL cholesterol, which is highly atherogenic, and I'll show you why. This is an LDL particle, and every LDL particle on its outer surface has an apolipoprotein B molecule. And this apolipoprotein B molecule, which is the one which gives atherogenicity. So when we measure LDL mass, we are measuring its weight. So larger particles, small number of ApoB will have higher mass. So you have the Western population on an average having 200 to 230 milligrams per deciliter of cholesterol, whereas Nepalese, Indian, Bangladeshi population, average rural population has around 160, 150 to 160. This is such a big difference. But despite that, we have high burden of coronary artery disease. And this was again studied in the Interheart study, which showed that South Asian cases have high ApoB to ApoA1 ratio. ApoA1 is on the HDL cholesterol, which is protective. So we did a comparison from our own cohort study. This is a cross-sectional comparison of the US population, the NAHN study, and our population. Look at LDL cholesterol levels in India and the US. In the US, LDL cholesterol was much higher as compared to the Indian population, and the reverse was true. So when we are managing our lipids, we still manage LDL cholesterol. So we need to ask the question, are we looking at the right markers? So we need to, and this is a representation of each of the lipid profile, and clearly what is emerging is ApoB is higher in South Asians and triglycerides are higher, and therefore we require a new way of looking at ApoB management. So ApoB is a single atherogenic lipid marker present in all lipid subfractions. It integrates and extends information from the triglycerides and cholesterol, and the conventional lipid panel is complex and can be confusing and sometimes contradictory. So I think we need to look at ApoB, and we are actually doing the analysis for a longitudinal study, and by the end of this year, we'll get the results. Lastly, I want to talk something about the environmental determinants of cardiovascular health. This whole world is undergoing climate change. Climate change can result in extremes of temperature, relative humidity, floods, droughts, and cyclones. It can result in hemodynamic changes, heat stress resulting in increased stroke and increased heart attacks. There's livelihood uncertainty, malnutrition, and reduction in crop yield, leading to food insecurity. Air pollution, particularly particulate matter 2.5 and several other exposomes, can produce inflammation, oxidative stress, imbalance in autonomic nervous system, endothelial dysfunction, DNA methylation. And water pollution, heavy metals, and others through persistent organic pollutants, lead, cadmium, mercury, and arsenic can again cause several damage to the cells, ultimately resulting in high cardiovascular risk factors, hypertension, diabetes, and insulin resistance, heart failure, and increased cardiovascular mortality. So the question is there evidence? We have recently published that long and short-term exposure to increased particulate matter concentrations associated with increased blood pressure and risk of developing hypertension in India. For every 25 microgram per cubic meter of PM2.5, the blood pressure increases by 3.5 to 5 millimeters of mercury. So if we achieve national ambient air quality standards, we can potentially decrease the prevalence of hypertension by 15% in urban Delhi. This is the power of intervention at a policy level, at a social determinant level. So even currently, Delhi has a PM2.5 value of 100, average value of 100. If we reduce it to 75, we can reduce the prevalence of hypertension by 5%. We have also shown the link with diabetes, and we are working on the other things listed here. So identifying cardiovascular disease or NCD risk in South Asians, what is needed? There are two things which we talk about. One, we use the Framingham method where we are looking at etiological or degenerative or adult model. And the second is the early life developmental model, which was proposed by Barker and others. And we need to combine this and look at a life course model, because this is a disease which starts in the womb and ends at death. There's accumulation of risk, and there's longitudinal risk accumulation across the lifespan from biological and social factors. So we are programmed individuals, be it because of genetic, fetal programming, or epigenetic changes in early life determinants. And there are several environmental triggers: diet, physical activity, smoking, environmental pollution, and others, resulting in cardiovascular disease. We also have developed intermediate phenotype. I showed you the example of why we have high propensity to diabetes, and these directly increase the risk for cardiovascular disease. And finally, increasing high cardiovascular mortality, where health system and equity comes in because of biology, personal beliefs, life course, socioeconomic status issues, and health system response increases mortality for people who develop the disease. So the South Asian phenotype appears to be conditioned by fetal programming, genetic or epigenetic evolutionary changes, and hence is like a loaded gun. So what do we do? Keep the loaded gun under lock and key, or unload the gun, or eliminate the triggers. So we can do all of these actually. So this was a slide which I used to use around 15 years back, and we used to say that there is this saying by the Marathas, old Marathas saying, when they attacked Delhi, they said, strike, strike at the trunk and the branches will fall off themselves. Now we know what takes it to change the soil. We can actually change the soil. So we start prevention from pregnancy, even before birth, continue the prevention, and a whole range of changes can be made at policy level, at health system level, and at individual level in terms of combating cardiovascular disease amongst South Asians. So thank you very much.
Thank you, Professor Prabhakaran. It was very informative, very comprehensive, and very enlightening talk. Please stay with us, and we'll get some of the questions at the end. Now, I would like to invite Dr. Meghnad Dhimal. His topic of presentation would be the climate change, health and equity, growing ethical crisis. Most of you know Dr. Dhimal, but let me introduce him as an environmental health scientist with over 20 years of experience working in Nepal and abroad. His primary area of expertise is on environmental health, with more focus on climate change and health. Currently, he works as a senior research officer at the Nepal Health Research Council. He's also an associate academician at Nepal Academy of Science and Technology, NAST. He's a visiting faculty of environmental health at Tribhuvan University and Yale School of Public Health, Yale University, USA. He's a recipient of Young Scientist Award of year 2015 by NAST, winner of New Voices in Global Health Programs at the World Health Summit 2017, and Outstanding Health Research Award in 2018 from NHRC, and NAST Award of Health Sector 2022 from Ministry of Education. He's also recipient of Institute of Tropical Medicine Scientific Excellence Award 2023. He's the first Nepali who has been elected as a Fellow of International Science Council since December 2023, which is the highest honor that can be conferred on an individual by ISC, as International Science Council. With all this long and very important introduction, let me invite Dr. Dhimal to give his talk.
Thank you so much, respected Chair, for a nice introduction. And all the delegates of the summits, it's my really great pleasure to talk about the issue of climate change, health and equity, growing ethical crisis. And many thanks to my previous speaker, Professor Harris and Professor Prabhakaran, whose talk is also a bit linked with this equity and health issue. And now the climate change is a confounder that will further increase this injustice and further increase this inequality. That's why I choose this topic, and my next colleague, Dr. Sushil Chandra Baral, will dig out further on this inequity issue. So, in my presentation, broadly, I'll talk about the overview of health impact of climate change, and since last 2 days we are talking, so I'll not go in detail. Second, I'll talk about the climate change, health and equity from the divided old perspective. Third, I'll talk about the ethical crisis in climate change and health. And finally, something or some solution is needed. So I'll just share the experience of Nepal on health sector response to climate change, and finally way forward. So I have just quoted the two very important verbatim. One is from the Jim Yong Kim from the World Bank, and next from the Margaret Chan of WHO. And their statement is very loud and clear. Climate change threatens our fragile existence on this planet. Means poorest of the poor will be the most vulnerable. That's why climate change will further increase the inequality. Second, for public health, climate change is the defining issue for the 21st century. We are very eager to know that how the climate change affects the public health. And is it the issue of only public health or other people's? Or what's the business of public health? I think there is not a common understanding. But I think climate change will provide the forum to bring all the disciplinary together and can break the silos. And that understanding is needed in today's world. And if you see how the climate change affects the health, in the past we talk about the effect on the malaria, dengue, Zika virus, but now it affects every stage of life. Means we need to think from life course approach. Any pregnant woman who have the fetus in the womb, they are also now, experience the heat stroke. They are also experience the risks of the vector-borne disease. They are also experience the risks of the mental illness. Because through the direct ways and indirect ways, or maybe through the indirect way like the malnutrition, because of the impact in the agriculture systems. That means climate change increases the vulnerability, and that depends through the demographic factors, or the geographical factors, or the biological factors and health status, or through the exposure pathway like the extreme weather events, or through the heat stress, or through the air quality like just Professor Prabhakaran mentioned. Climate change increases the air pollution, and air pollution also increases the climate change. But if we do the timely actions, means there is a huge health co-benefits. And next important part is the health system capacity and resilience. If our public health system is very strong, we can avoid that mortality and morbidity. But if our health system is weak, means our health system might be collapsed or cannot respond timely to the additional burden of climate change. So, based on that, there could be several climate-sensitive health risks and disease, starting from injury, mental health, displacement of populations, migrations, infectious disease, so many. And yesterday we see also the impact of climate change on reproductive and sexual health. That means, as we are talking with the SDG issue now, means climate change is interlinked with all the 17 SDG, not only SDG 13, which is linked about the climate action, or not only SDG 3rd, which is linked with the health and well-being. It affects to gender, it affects to the education, it affects to the safe drinking water and hygiene. So they are interconnections, and we need to address in a holistic way. And WHO has a projections. By between 2030 and 50, there might be 250,000 additional mortality, excess mortality from the climate change. And most of this death occurs because of diarrheal disease or the malnutrition or the injuries. And where does that happen? Means most of the death will occur in the global south or in low and middle income countries. And recent Lancet Countdown report, which just published in November this year before the Conference of Party, and the chair of the Lancet Countdown, Professor Anthony Costello, clearly presented a study. Means there is a huge impact of the climate change, and the old is in a very fear old. That means how we'll experience the impact now and in the futures. Just I want to summarize that in 2023, the world saw the highest global temperature in over 100,000 years. And heat records were broken in all continents through 2022. Though the Paris Agreement mentioned that we need to maintain the temperature below 1.5 degrees centigrade at the end of century. But the temperature has already increased 1.014 in last 1 decade. And it is most likely that it will increase about 2.7 degrees centigrade. And the projections show that if the temperature rises reach 2 degrees centigrade already by mid-century, heat-related deaths are projected to increase by 370%. And that is linked with the economy that heat-related labor loss is projected to increase by 50%. Around 25 million additional people are projected to expose moderate to severe food insecurity. And the transmission potential for dengue is projected to increase up to 37. And in case of Nepal, it will be 100% that we have already witnessed. There was no dengue till 2004, but if you see the 2019 or 2022 or 2023 outbreak, all districts of Nepal reported the dengue cases with the more than 50,000 cases. And this is the issue of equity also. Though United Nations Framework Convention on Climate Change has clearly mentioned about the adaptation based on the equity and in accordance with their common but different responsibility in respect to capacities, but still it is not in practice. And the major emission come from the global north, but still victim are the global south. And we are talking the several conference of party, and we are talking about loss and damage, but still we need to mainstream how can we really translate that loss and damage principle into actions. And climate change is truly a global phenomenon. And once there is an emission of the greenhouse gases, they have a thousands, even a million years of residual effect. Means the gas could be emitted from any part of the world, but there will be the impact globally, but the most affected will be the people who have the low capping capacity, means the poorest of the poor people. And this is quite old, but very important cartograms published in Nature in 2007. This show that cumulative emission of the greenhouse gases to 2002, see, most of the greenhouse gases, more than 90%, come from global north, means developed country. But if you see the WHO estimates of per capita mortality from climate-sensitive disease, means most of the disease burden occur in global south. That is why it is a divided world, and there is a growing ethical crisis. Because some are the emitter, but the victims are others. And next important point, if you see the publication on climate change and health, where does that come? All from, again, developed country. And developing country has the very few publications. It is just started growing in last 1 decade, I'll say. Right? And the absence of the evidence should not be the excuse for the actions. We have already a problem, right? But there is no resource to generate the evidences. And we cannot wait long for the timely actions. And next important point is the international collaborations. Because we should avoid the concept of I or my country. We should go beyond that boundary. But still, we don't have a culture of collaborations. There is a North-North collaboration, very strong, and in some extent global North and South collaboration, but where is global South and South collaboration? That is missing because of the messy politics. Like there is a politics in SAARC, there is a politics in Bismarck, and other. But I think through the science diplomacy, all scientists can unite together, and I think there is an ample opportunity for the collaboration between global South and South, as well as global South and North. That is demanded by this diagram. Now, next point is the climate and health and ethics. If I open my inbox morning, every morning I get maybe 10 to 15 email requesting to be a research participants, because there are the several universities in global North want to do the research on ethics and infectious disease, ethics and NCD, ethics and mental health. That means they are working. But if you see the authorship letter, means I think all will be from the global North. Means we also know the methods. Why don't we are in silos? I think we need to work, right? Otherwise, again, that will be dominated by the global North about the ethics matters, right? So there is a lack of understanding of the importance of the ethics in policy response to health and climate change. Globally, not only in Nepal, but hopefully by next year there will be the thousands of literature in the PubMed from the global North. And the interactions between the health, climate change, and ethics is technically and theoretically complex, and work in this area is fragmentary, unfocused, and underdeveloped. And research and reflection on climate and health is fragmented, plagued by the disciplinary silos. I already told this is my field. I am public health, I am nursing, I am medicines. I think we need to break that silos, and exponentially increasing the literature means that the field cannot be synthesized using the conventional methods. Means we need to think from new horizons. And especially in the low SDI countries, they are underrepresented in research and publication, both in the health impact of climate change and the normative reflection on health and climate change policy. So aspects of justice relevant to climate change include basically inequalities in who has contributed to climate change, and inequalities in who is most harmed by the climate change, and opportunities also to rectify injustice while addressing the climate change. These are the very important points that we need to consider when we develop the ethics and climate change. And there are several gaps that I don't want to highlight now because of the limited time. And the big issue is that, some are the emitters, some are, passing the luxurious life, but there are the other people who are the victims. Like some are using the AC or the air conditions, but other people are the victim, means poorest of poor in the road, right? So it is a time for actions. So no plan means no planet. We need to think the planetary health. And for that, WHO has clearly developed a resilient framework that we can adopt. So because of time, I'll just summarize in a little bit. Now I want to go to the health sector response to climate change in Nepal. Maybe in next 2 and 3 minutes, I'll finish this. So actually Nepal, in 2007, first we organized the National Workshop on Climate Change and Health. That was the first, and I think I'm happy many colleagues are also here in this room. So that was a historical event. And immediately I wrote an article to the Lancet, and that documented that there is a lack of public policy. I know lack is not good word, but there are clearly lack. And lack of trained human resources, no political priority, and focus on national policy, low financial capacity, lack of research material, lack of coordination. And even I got a threat to withdraw that paper at that time, to be very frank. But as a scientist, I wrote the truth. But now, the research conducted in Nepal are, widely in the UN report and others, right? And there is a great response of government of Nepal on this issue. I'm quite proud on this field because, like yesterday we discussed, Maldives organized the meeting below the sea level to draw the international attention that they are at risk of sea level, and immediately Nepal organized in the cabinet meeting in Kalapathar to draw the international attention that Nepal is also at risk of Gulf and others. And now we have several policy documents which address this, climate change. But the question is that we have a very good document, but the translation is a question. And for that, we need to increase our financial capacity. We have a limited fiscal space. For that, we cannot cry and say we are the most vulnerable country. We need to enhance our technical capacity, and we have to secure the international funding through the loss and damage fund or the adaptation fund. So we developed the SNAP. I see Dr. Khemkari, who took the leadership. We developed and we become the model country in South Asia, also globally. And we also train the colleagues from the Global South, and leadership of Dr. Bolaram Shrestha sir at that time, means we did in Nepal. It went to the ministerial meeting in Mali, develop a framework for the climate resilient health systems. And also we have already updated it for the 2020 to 2030s. So in the COP 28 in Dubai, it was the first health day celebrated. Globally also it is a neglected issue. And our Prime Minister also there, Health Minister was there, and almost 2.4% health delegates were there. Means that was 14,000. Means among the 85 delegates, 14,000 were from health sector. That was quite good. And there is a $1 billion commitment for climate and health project only. But to trap that fund means we need to enhance our capacity. So the lesson learned of my last 20 years work on the climate change and health in Nepal, Maldives, Timor-Leste, and several other countries, that national capacity building is a key for adaptations. Both climate change mitigation and adaptation should be a priority of all countries. And developing collaboration, networking, and partnership is key for addressing the global health issues such as climate and health. That collaboration networking doesn't mean that international only. Within the national and interdisciplinary collaboration is also very important. Next, production of health workforce to address the health risks of climate change, breaking the disciplinary silence is very important. In the past, we assumed that this is the issue of only climate scientists, but it is not anymore. It is a public health crisis. And WHO is going to announce this public health emergency for the climate change very soon, because European Parliament has already given the decisions. And finally, maintaining the planetary health is essential for the human and societal health and a precondition for climate resilient development, adopting a principle of equity and ethics. Thank you so much for your listening. Thank you.
Thank you, Dr. Dhimal, for such a highlighting topic on climate change, the impact of climate change being more on the places or areas where more disparity and inequities is there in health system. And really you have mentioned it as a climate crisis in another word. So with continuum to your topic, I would invite the last speaker of this session, Dr. Sushil Chandra Baral. He is a renowned person. He has more than 25 years of professional experience in health system and policy research, health system strengthening and public health matters in developing countries like us. He is the founder chair of National Public Health Institution, Health Research and Social Development Forum, and also the founding director of HUD International. He will be talking on From Disparity to Dignity, a narrative of Nepal's health system on equity. Dr. Baral, please go ahead.
Thank you very much. Respected chairs, my fellow presenters, gurus, my colleagues, and most importantly, very young, energetic scientists, researchers in health and population sector. Jadau, namaskar, a very warm welcome and good morning to you all. आउँदै गरेको नव वर्षको शुभकामना सहित म यहाँहरुसँग next 20 minutes I will be with you. I'll be switching in between Nepali and English. Neither my English is good nor my Nepali is, but I will be talking in between. The topic of the today I've chosen is from the disparity to dignity. This is a narrative that I want to bring towards you across the last 30 years in Nepal, how we travel through the journey from the disparity to the dignity, where we stand today from the different dimensions. At the very outset, I really want to mention that inequity can be understood, unleashed, explained using a different framework, various aspects. But I and my colleagues, co-authors, have chosen a different set today. Perhaps you have seen these numbers in different colors, different bars, different diagrams. But I'll be trying to explain it in our way, the way we think appropriate for this audience. Right, I deliberately choose the word disparity, debate, and put the dignity somewhere in the top, trying to understand. I have created a hypothesis here. Politics is the driver of inequity if the political choices are made wrong. But in the other hand, politics is the driver of equity if the choices are made in right directions. In this context, I'll be really fleshing out a bit more detail looking at the policies, politics, and people in this equity journey. I strongly believe that political process, political forces, they form the government and they form the policies. And these policies basically guides the health system. The health and well-being of any citizen in the country is guided by the politics and policies. So we will be having a bit deeper look at how our policies are shaped, are unshaped towards equitable health gains and well-being in this country over the last 30 years. How the programs have been designed, implemented, and exercised enough with the highest impact, with the level of scalability and the high coverage, so we attain the journey from disparity to the dignity. हामी सबैले यो देखेको कुरा हो. My apology, this slide in Nepali. I've taken the manifesto of political parties, starting from 1985, 1990, then onwards, focusing on, and I've chosen deliberately 3 different elections to look at the commitment of the political party towards the nation, people, and the health and well-being. No big difference, my friend. All the political parties have demonstrated this commitment during the election that we will have health and well-being at the center. Great. Very important. That's why I strongly believe that politics saves the country. This is the commitment from the various parties, including the traditional parties and the new parties in the election 2022, which talks largely, some of them, they talk the numbers, coverage 100%, bringing changes particularly among the people residing in rural area with the low health gains, bringing equity on forces. It's very important. I salute all the political parties for making this good commitment to the people, but the matters on its delivery. Looking at the policy and power, how the policies have shaped over the years, over the last 3 decades. My apology, this clumsy slide, but I had to present this to you. Looking at the national health policy in 1991, up to the JESI strategy 2023, which I consider is the latest document, as well as the Nepal Health Sector Strategic Plan, which has recently been endorsed by the government of Nepal. We all talk about equity in health sector. All the policies in different ways have addressed the equity concerns. And various milestones I have set, I and my co-authors have said, in order to unfold deeply how the policy shapes or de-shapes the equity in health sector. We'll be making it public in our paper later on, but this is the journey from disparity to dignity I wanted to really unfold here. How these policies have been translated in health systems towards more resilient, more inclusive, more result-oriented. So our health interventions are more specific efficient, result-driven. And the health gains are up to the optimal towards samunnati, right? Just one thing I want to highlight throughout this presentation. One is the population parameter. Looking at the Madhesh, which holds the large set of the population, please bear in mind my subsequent slides, you need to visualize this population parameter. But here is the unequal status. I don't expect a homogeneous population across the provinces. There are the differences, understandable. But the Human Development Index, disparity in the Human Development Index is unacceptable. Looking at the per capita income, our political commitment to some extent has been translated towards the allocation of the resources for the health sector, where you see the percentage has increased, GDP per capita, rolling 3-year period, which I really appreciate. But has that brought the result that we actually wanted to gain? Is this enough, the trend that we have today? Looking at this, who spends most out-of-pocket expenditure, whether it's a catastrophe or that has contributed to impoverishment of the people? These slides, I just want to focus. Poorest are spending comparatively less compared to richest. Very good. It seems proper. But if you look at the impoverishment data, even the poor are spending less out-of-pocket expenditure in health, but their impoverishment is far higher than any other category. So this is the point I really wanted to note for you all. Distribution of health institutions. We looked at Madhesh, which comprises the highest population. But if you look at the Madhesh in second row, which has the very less number of public hospitals compared to the population, as well as the number of primary healthcare centers, number of health posts, and number of basic primary healthcare centers. Are we translating our political commitment towards the evidence and reality across it? That's the major question from this slide I really wanted to highlight. Our policies are good, but not necessarily our practice has onboarded the good policy in hand. The distribution of health facilities. Again, there are certain provinces with zero. I do not want to see in the next few years the zero in terms of the services. What made us not to be strategic in terms of distribution of our health facilities and human resources? If we know where we need to hit, perhaps we know by the evidence that we have today. Again, the human resources distribution across the provinces has not justifiable enough. Why this is happening? Why the higher concentration of human resources, including the speciality in certain provinces, not in across? There are problems translating policies into the real world. This is what the consideration we need to make. Perhaps you have seen these numbers several times, but I'm trying to really bring a different dimension here from the politics, policies, and power. Food insecurity in Nepal. Why the Karnali always has to top on the bar? It's very important. If you look at over the last 30 years of the development trajectory in Nepal, where the Karnali always sits in the very highly unsecured from the food security perspective. What are the policies, what we are taking enough to drive this curve? What our policy clearly mentions that all the population segment will have access within the 30-minute distance. This is what the national policy talks about us. But still, if you look at this, in rural area in particular, only the 65% of the population within the reach of 30 minutes. This clearly demonstrates the statistic distribution of the health facilities looking at the population and geography, which policy states very loud and clear, but in practice, this has not been translated. I totally understand there are limitations, but these limitations are within our merit to deliver effectively. Again, the distance from the perceived barriers, it has reduced compared to 2016 and 2022. People seem to be a bit more satisfied what has taken place in, compared to 2016 and 2022. However, there is a considerable perceived barrier still exists across, be that in rural or overall in urban area. I have no particular fit for this should be the TFR in this country. I'm not arguing on that. But looking at the 1996, where if you look at the no education and higher education quintile here group, it's 1996, 2.3 with the higher education and 5.1 to the no education. Education has a strong driver of inequity in this country, which was not understood yesterday, but it has been evident for a number of years. Also, looking at the caste and ethnicity, which seem to be a strong driver in this country for health inequity. The Muslim population with a 3.3 TFR rate, which puts in danger in many ways when there is a high TFR for the women and children. This is an interesting slide. Of course, all slides are interesting, I guess. But let me have a deep dive. I have looked at 1996 from 2022, almost 30 years, 28 years. If you look at the no education and higher education, and looking at the place of delivery in health facility, in 1996, 4.1 uneducated women were delivering at health facility, whereas almost 70% educated, higher educated women were delivering in health facility. The gap between these two was 66%. That 66% gap after 28 years still persists to the 40%. Have we done enough in terms of narrowing the gap between these groups? We are enjoying overall gains in health sector, but gain has to be equitable. If you really want to address the different segment of the population need in health, policies, programs, politics, all these three should be geared enough towards narrowing the gap between these two. Likewise, in child stunting, we had 46% difference between in 96, which has reduced to 25, but is still considerably high. नेपालीमा भन्न मन लाग्छ यो सहन योग्य फरक होइन. We need to do something. Likewise, if you look at the neonatal mortality, considerable reduction in terms of from the 43% in 2001 to 2022, but still again. म लगभग 15 मिनट सकिन लागेको छ. I'll try to wrap within 5 minutes if I'm allowed extra. ANC visits. हामीले हेर्दाखेरि what we see here is the highest increase of 4 ANC plus visits if you compare from 2016 to 2023 from the DHS data. Karnali seemed to be the first unit in terms of increase. This is good evidence. However, if you look at how does it translate to the mortality, the impact indicator, it does not correlate very much. Likewise, if you look at these social determinants associated with the ANC dropout, with the multivariate regression analysis, again, education, no education seemed to be the higher dropout during ANC. The poorest are the higher dropout, as well as the province 1, province 2 seem to be Madhes where the higher dropout. So we have evidence which clearly demonstrate where we need to trigger our focus if we want to really reduce health inequity in Nepal. Again, institutional delivery. Highest percentage change occurred between 2016 to 2022, which is Karnali. But it has not translated to the mortality indicator, impact indicator. Still, there is a gap. This is only slide where the richest quintile has the highest burden, NCD. But the lowest quintile, the burden is still high. How do we reverse this? It is not that I want to see all the slides like this, but there is a trend. We have effective coverage of services for a certain segment of population, but not for all. Again, I don't want to go detail on this thing, but it's education, wealth quintile, and the provinces which are lagging behind is in maternal health service coverage indicator in terms of provinces 3 and 4. 2 is the Madhes province is the lowest one. This is interesting slide, another interesting slide, I would say. The far side of the slide, which compares from 2001 to 2030, where we need to go in terms of hitting our SDGs. The difference, the wealth quintile difference, highest wealth quintile and lowest wealth quintile, the difference in 2021 in terms of institutional, 2001 institutional delivery, which was around like 34%. But that difference increased. In 2006, it was 50%, and then 66%. And that dropped down to 55, and it still exists almost 32% difference between the quintile. Despite the fact that you will see the policy intervention across various timelines, whether or not these policies were pro-poor, these interventions were pro-poor in order to reduce the gaps within the quintile is the biggest question. If you look at the annual rate of reduction, richest quintile, if we don't do anything substantial now, richest quintile will continue to attain the SDG target. But we need to do more on the lowest wealth quintile, which requires almost 5% annual reduction in mortality in terms of delivery, which is a toughest game. Tuberculosis, also, its poorest are the worst hit, and the highest age groups are the worst hit. Interestingly, we all thought that crisis like COVID has impact across the population segment, perhaps similar way. But if you look at the home delivery conducted during the time of crisis, better off people, richest people, were somehow navigating themselves toward the institution, although we had lockdown, but the poorest were the one basically forced to deliver at home, which increases the risk of mortality. Inequities in SBA-assisted deliveries. I've taken this graph. Among the poorest quintile, SBA delivery is more concentrated towards education. In this country, even if you are poor, but highly educated within the poor segment, you are more likely to gain better off services. Your results are better. But if you are rich and uneducated, but still your chances of getting higher gains is higher. So there is a distribution and a strong association between education and health outcomes that's been delivered. Again, this slide, I only want to concentrate on the annual rate of reduction here in terms of achieving MDG across the various provinces. Can Lumbini reduce 11.3% maternal mortality ratio to attain by 2030? it's a substantial effort is needed. We are at the verge of competing the priorities, but this cannot be overlooked. Again, the highest when quintile achieved something 51 years before than the poorest quintile in this country, which comes to the neonatal mortality rate. If you look at the projection made by the author, it clearly demonstrates something achieved 51 years ago for the highest quintile will continue to achieve 51 years later. Again, local level mortality, I don't want to go detail, but there are certain districts where has high focus compared to other. Again, disparities in neonatal mortality, under 5 mortality. I want to focus on annual rate of reduction if we want to achieve the SDG, which requires neonatal mortality 6.8% reduction and the under 5 mortality 3.4% reduction. How we can achieve this? Again, similar current rate of reduction and annual rate of reduction, I really want to highlight here, mountains seem to be the toughest priority if we want to accelerate the reduction in terms of under 5 mortality as well as the neonatal mortality, which is far high compared to the hill and terai. We have geographic distribution which triggers the inequity. And the disparity in child mortality also, again, if you look at the wealth quintile, poorest, richest we have already achieved for the under 5. But if we want to really achieve within the poorest segment of the community, we need 9% annual rate of reduction, which is really, really a tough challenge for the health system to achieve. Again, quite a lot discussed in the last 2 days on the teenage pregnancy and childbearing. If you look at the percentage of women 15 to 19 who have begun the childbearing facility, looking at 1996 and 2006, the gain has not been changed over the years. We have similar in nutrition, disparities in inequities and child nutrition. Our policy says 100% coverage. If you look at the political manifesto, insurance will be covered in this country 100%. But this is what the reality data speaks. I love in the audience row some of the politicians to look at this slide more strongly and reflect and go back and talk how we can strengthen the coverage of the quality of health insurance. Absolutely undeniable, political commitments seem to be very progressive in nature towards the health and well-being of the people in this country. Hamra नीतिहरू बिस्तारै progressive, प्रगतिशील भएको देखिन्छ. हाम्रो स्वास्थ्य सेवा प्रणाली विषमता छ, अनुकूलता कम हुँदै पनि बढी भन्दा बढी स्वास्थ्यका अङ्कहरू ल्याउनेतिर प्रगतिशील देखिन्छ. यद्यपि हाम्रो स्वास्थ्यका उपलब्धिहरू समतामूलक छैनन्. हामीले लिएको दिशानिर्देश कार्यक्रमहरू जसले एउटा समतामूलक गेनतर्फ अगाडि बढेको देखिन्छ, तर आउनुहोस्, we have enough evidence, we have enough known to act better. To act like हामी, we need collective actions toward the geared up effort in order to reduce inequity. Ultimately, मेरो यो political lens, the policies and the outcome and the health systems, यहाँहरूले धैर्यतापूर्वक सुनिदिनु भयो, सायद माया पनि गरिदिनु भयो होला. यहाँको लागि धन्यवाद. जदौ भन्न चाहन्छु. Thank you very much.
Thank you, Dr. Baral. Very comprehensive presentation of the health status of the country and the determinants and the huge gap that we have to achieve the SDGs. I think we completed the presentations by and large. Now the floor will be open for discussion. What I would like you to do is make notes and indicate to whom you want to direct the question, please. And please, volunteers, give the microphones to those who raise hands. And if there are many, then we'll give you the order. Please don't jump into microphones. We will kind of give you time, okay? Let's keep the questions very short, precise, rather than making comments. Ask questions, please. And
hello. Okay.
And also reminder that Professor Harris is online. He would still take his questions. That's what I'm informed.
One short question, not Please. Question. Request for input to Meghanathi. You mentioned lack of political priority in tackling the climate change issue. What will be your suggestion in 1, 2, 3, 4 to the political parties, to you? And to Dr. Sushil, you have mentioned the words poorest, poorer, richest, richer. I don't think there is clear-cut national economic stratification. Even BPL is still not clear. How could you define that poorest, poorer, or like that? Thank you.
Hello. All right. Can you, maybe we respond quickly, otherwise.
So, thank you so much, Dr. Packrell, for a very nice questions. I just want to clarify that lack of political commitment was in 2008, not now. Okay? So, before 2010, we had no any policy document mentioning climate change and health. No in political manifesto. But today, Nepal is a model country to mainstream health in climate change and climate change in health sectors. That's why we have a big progress. But now the question is translating these policy documents into actions. For that, we need to increase our fiscal space. So as the domestic funding is limited, we need to access or secure the international funding. For that, we need to unite, develop the networking, collaboration, partnership, and capacity building. That is the message. Thank you.
Thank you, Dr. Subhas. All this secondary data analysis we took from the various sources, and the classification of the well quintile has been divided like this. But there is no political clear-cut definition which segment of the population and the percentage of the population fall within what range. But there is a composite indicator which used in these various surveys to compute the poorest, richest, middle, and higher wealth quintile. Thank you very much.
Are there any more questions to any of the speakers, including Dr. Harris?
Jai Shri Krishna, everyone. Amit Kumar Yadav, Maharajan Medical Campus, IIM. मैले एउटा सानो टपिकमा रिसर्च गरेको थिएँ हैन लङ क्यान्सरको बारेमा। त्यहाँ मैले एउटा धेरै दुःखद कुराहरू पनि देखेँ किनकि टोब्याको अनि सिगारेट प्रोडक्टमा नेपालले इम्पोर्ट धेरै गर्छ, हाई ट्याक्स लिन्छ र त्यही ट्याक्सबाट क्यान्सर रिलेटेड मेडिसिन किन्छ र पेशेन्टमा मुफ्त अथवा फ्रीमा पनि दिन्छ। मैले हेर्न खोजेको भनेपछि मेरो गाउँमा मान्छेहरूले पिज्जा चोरेर र लुकाएर पनि खान सक्दैन किनकि त्यहाँ चाहिँ कुनै पनि ठाउँमा पिज्जा बेच्दैन। हामीले चाहिँ भारत जस्तै रातारात चाहिँ टोब्याको प्रोडक्ट र टोब्याको कन्जम्पसनमा पनि किन रोक लाउन सक्दैनौँ किनकि टोब्याको र टोब्याको प्रोडक्ट सिगारेट जस्ता कुराहरू कुनै पनि एंगलले पनि राम्रो देखिदैन र यसले चाहिँ धेरै यहाँ डिस्क्राइब गरेको धेरै कुराहरूमा पनि डाइरेक्ट असर गर्छ, हाम्रो शरीरको हरेक अङ्गमा पनि डाइरेक्ट असर गर्छ। र मैले हेर्दाखेरि एनएचआरसी र स्वास्थ्य मन्त्रालय भन्दा नेपालमा कुनै पनि ठुलो अर्गनाइजेसन छैन जसले चाहिँ यसमा डाइरेक्ट एक्सन लिन सकिन्छ र त्यसैले मलाई चाहिँ के अनुरोध गर्न मन छ भनेपछि यो दुईटै संस्थाले मिलेर कुनै दिन रातारात टोब्याको प्रोडक्ट र कन्जम्पसनमा पनि रोक लगाइदियोस् भनेर किनकि यसले चाहिँ एकदम धेरै नकारात्मक असर गरिरहेछ र यसले गर्न सकिँदैन भनेपछि रोकिन्छ कहाँ र कसले रोकिरहेछ त्यो पनि मलाई चाहिँ जान्न मन लागेछ। हस्तै
धन्यवाद तपाईको प्रश्नको लागि। अब औपचारिक रूपमा प्रश्नको चाहिँ जवाफ दिने हामी हैसियतमा छैनौँ, यो रातारात कम्प्लिट ब्यान गर्ने कुरा। तर एज अ सिटिजन, एज एन इन्डिभिजुअल वर्किङ इन दिस फिल्ड, मिनिस्ट्रीमा धेरै वर्षदेखि इन्क्लुडिङ एन्टी टोब्याको क्याम्पेनमा लागेको हिसाबले हामीले संसारको एक्सपिरियन्सले, नेपालको एक्सपिरियन्सले सटडाउन गर्ने कुरा चाहिँ व्यवहारिक नहुने रहेछ, नसकिने रहेछ, अहिलेलाई त्यति नै भनौँ। तर विभिन्न तौर तरिकाले डिस्करेज गर्ने, एडभर्टिजमेन्टहरू गरे, प्रचार ब्यान गर्ने तर्साउने खाले मेसेजहरू दिने, ट्याक्स बढाउने लगायतका काम भइरहेछन्। तर अहिले पनि हामी के चाहिँ मान्छौँ र हाम्रो एडभोकेसी के हो भने यो ट्याक्स चाहिँ अझै बढाउनु पर्यो। कम्प्लिट कन्जम्सन ब्यान चाहिँ नट स्योर। हि इज कोटिङ इन्डिया that there could have been a harder control in tobacco procurement, import and distribution. You have any quick comment on how India has taken the ban on tobacco ban as a policy?
Sorry? Okay. So, in terms of tobacco control, I don't think there is a tobacco ban as such. In terms of tobacco control, there have been multiple activities. Number one is increase taxation on tobacco products, particularly cigarettes. It went up by almost 72%, and that's shown some results in terms of reduction in smoking. From an average of 14% in 2008, 2009, it's come down to around 9% now. So there's a clear decrease in tobacco smoking. But where we fail is in control of BD smoking, because BD is classified as small-scale industry. So taxation kicks in when they make a certain number. I think it's around 200,000 bundles or something like that. So most of them are below that. So that's one. Second is chewing of tobacco products. It's still very high. The second thing is pictorial warnings. There's been a lot of advocacy in terms of increasing the pictorial warning size, but counter push from the tobacco industry has resulted in diluted warnings, I should say. So that's the second problem. The third is sale of cigarettes to minors. It still happens because one of the things which is propounded is that you should not sell loose products, but it still happens, and because of that, children can buy and then they can get addicted. And there are other measures. I mean, one area where India has been strong is advertisements. Both surrogate as well as real advertisement is banned, and it's not there. But point of sale advertising is still there. They can put, at the place where they sell the cigarettes, they can put a poster. So that's kind of unregulated. Then the last one is ban of smoking in public places. Over a period of time, it has actually been implemented in most cities at least, but in smaller cities and rural areas, it's still not very firmly implemented. So I think we need more work. We are not at the level of Ireland, Australia, or New Zealand, who are looking at tobacco-free societies. So we are still not there. We have to get tobacco use to less than 5%, and that will take time.
एउटा सानो एक्जाम्पल चाहिँ जस्तो पोलिसीमा अथवा इन्डिभिजुअल केस बेसिसमा यो अलि अल अर नन फेनोमेनामा ठ्याक्कै जाँदैन, तर स्ट्रङ डिटर्मिनेसन र एक्जिक्युसनमा काम त भइरहेकै छ। मेरो एउटा केस स्टडी छ, हामीले 100 जना एकदम रेगुलर अल्कोहल कन्ज्युमरलाई चाहिँ रक्सी 1/3 ले कट अफ गर्न भन्यौँ, अर्को 100 जनालाई चाहिँ एब्स्टिनेन्स नै गर्न भन्यौँ। एब्स्टिनेन्स गरेकोहरूले एब्स्टिनेन्स त गरे, तर आफ्टर 6 मन्थ 75% ले फेरि सुरु गर्यो त्यही डोजमा। तर जसलाई चाहिँ कट अफ गर्नु 1/3 भनेको थियो, उनीहरू एकदम एडियर भर बस्यो र ओभरअलमा हेल्थ इम्प्याक्टमा त्यो एडियरवाला जसले 1/3 कटौती गर्यो, वी ह्याड गुड रिजल्ट। सो त्यसपछि अनि बल्ल फेरि अनि सटडाउनतिर लाग्नुपर्छ होला।
Thank you. Thank you. There were a couple hands. दुईटा हात उठाएको देखेको थिएँ, डाक्टर रिजाल र त्यहाँको। I think now please limit your remarks to questions, okay? Questions सोधौँ है। Dr. Rizal, please. Your microphone यहाँ दिनु त।
Okay, thank you. म नेपालमै भन्छु है।
ल नेपाल।
सबै प्रेजेन्टर्सहरूको वन्डरफुल प्रेजेन्टेसनलाई कङ्ग्रेचुलेसन भन्न चाहन्छु। मेरो क्वेसन्स अथवा क्वेरी विथ डाक्टर सुशील बराल, तपाईँले एजुकेसन, ह्याभ एजुकेसन एन्ड नट ह्याभ एजुकेसन अथवा चाहिँ हायर एजुकेसन भनेर भन्नुभयो। तपाईँ जस्तो एकदम रिसर्चर, एकदम डेप्थमा गएर रिसर्च गर्ने मान्छेसँग अर्को स्ट्याटिफाइड डाटा पनि अवश्य छ होला जस्तो लाग्छ मलाई। जस्तो पिपल विथ जस्ट लिटरेसी हु हेभ कम्प्लिटेड हाई स्कुल एजुकेसन एन्ड हु हेभ कम्प्लिटेड 12 भनौँ नेपाल गभर्मेन्टले दिने एजुकेसन भनेको 12 सम्मको एजुकेसन हो, फ्री अफ कस्ट भन्ने त्यो सम्म, र त्योभन्दा माथि ब्याचलर्स मास्टर्स पिएचडीको त अब त्यो हाम्रो ड्रिमको कुरा भयो होइन त्यस कारणले त्यो डाटा पनि छ भने के हाइलाइट गरिदिनुहुन्छ कि भन्छु थ्याङ्क यू विथ सरी त्यही हेल्थ स्टाटस विथ दिस एजुकेसन थ्याङ्क यू
धन्यवाद डाक्टर रिजाल उहाँ मेरो गुरु पनि हुनुहुन्छ नमस्कार मैले यो शिक्षाको विषयमा केही भेरिएबलहरू राखेर यो सेकेन्डरी एनालिसिसहरूमा हेरेको हो हामीसँग सेकेन्डरी एनालिसिसमा हेर्दाखेरि नो एजुकेसन बेसिक एजुकेसन सेकेन्डरी एजुकेसन हायर एजुकेसन भनेर डिस्ट्रिब्युट गरिएको छ ग्रुप गरिएको छ त्यो अनुसार मैले चाहिँ यहाँ प्रस्तुत गरेको स्लाइडमा नो एजुकेसन प्लस हायर एजुकेसनको बिट्विनको डिफरेन्स मात्रै हेर्न खोजेको हो डाक्टर साहबले भने जस्तै यो डेटाहरू एनडिएचएस लगायतमा एभाइलेबल छ यो हामीले आफैले जेनेरेट गरेको डेटा होइन तर त्यो एनालिसिस गर्न सकिन्छ हजुर यो सेकेन्डरी एजुकेसन अनि त्यसपछि +2 लेभलको एजुकेसन त्यो चाहिँ कुन भेरिएबलमा ग्रुप गरेको छ कसरी त्यसमा भर पर्छ तर डेफिनेटली हजुर नेक्स्ट उसमा 1 वर्ष त नकुरौँ हाम्रो केही पेपर आउँदैछ त्यसमा चाहिँ हामीले यो लेभलको एनालिसिस कन्सिडर गरेका छौँ धन्यवाद हजुर
अब 2-3टा क्वेसन एकैचोटि ल्याउँ टाइम धेरै जाने भयो एकछिन आल गिभ यु टाइम उहाँ अहिले उठिसक्नु भएको छ त्यसपछि बहिनीले हात उठाउनु भयो त्यसपछि सरले उठाउनु तीनजनाको क्वेसन सँगै लिउँ अनि आल डाइरेक्ट द क्वेसन टु द स्पिकर्स
Okay, good morning everyone. Myself Suraj Chand from Nepal Health Research Council Ethical Section. So I have a technical question for Professor Dr. Prabhakaran. It was very informative and quite nice presentation by you and thank you for that. And I'm very curious and I would like to hear a bit more information from you about, would you please not mind to give a bit more information regarding the circadian rhythm, biological clock linked with epigenetic modification and that's linked with cardiovascular diseases and what are the biomarkers that you are observing to do such type of researches? Thank you.
So if I understand the question, you're asking for the link between air pollution and epigenetic modification? Sorry? No, I didn't get the question.
Okay, actually, I just wanted to know about the biomarkers that you are looking to link these things together in research lab.
The biomarkers for cardiometabolic diseases?
Yes, yes.
So that's kind of, I mean, you have the conventional biomarkers, lipids, glucose, hemoglobin A1C and others. But in terms of advanced biomarkers, they are not necessary in terms of public policy, but they are necessary in terms of understanding the mechanism of disease. So the thing is, we are looking at inflammatory markers, we are looking at RAS biomarkers, we are looking at hypothalamic pituitary axis biomarkers in terms of looking at the disease. In terms of environmental health, we are looking at exposomes, which includes PM2.5, then nitric oxide, sulfur dioxide, ozone, black carbon, variations in temperature, noise, and multiple other things. In terms of DNA, the epigenetic studies, what we are looking at is DNA methylation caused by air pollution. But in addition, we are not looking at whole genome sequencing, but we are looking at proteomics. What are the protein products that actually increase the risk? So we are planning to do a nested case control study of 3,000 cases of coronary artery disease and heart failure put together against normal controls. That will take another 4 or 5 years to come.
Okay, thank you very much, sir.
Thank you.
Hello everyone. अस्तिदेखि कुरा गर्दाखेरि हेलो अस्तिदेखि कुरा गर्दाखेरि चाहिँ थ्योरी र हाम्रो रिसर्चमा चाहिँ धेरै कुराहरू देखिएको छ तर प्र्याक्टिसमा ट्रान्सलेट भएको छैन भन्ने कुरालाई नै हाइलाइट गर्न चाहन्छु र डाक्टर धिमाललाई चाहिँ म के प्रश्न गर्न चाहन्छु भने व्हाट आर द च्यालेन्ज डु यु फेस एज अ एनएचआरसीको एस्पेक्टमा हेर्दाखेरि पनि तपाईलाई त्यो ट्रान्सलेट गर्न, किनभने अहिले सुन्दाखेरि 5 to 10 इयर्समा चाहिँ क्लाइमेट चेन्ज एन्ड हेल्थ चाहिँ इट्स अ बिग थिङ होइन. सरी टु से इट्स अल्सो अ जार्गन हामीले धेरै युज गरिरहेको, बट स्टिल इट हेज बिन हाइलाइटेड एन्ड रिसर्च पनि धेरै कुराहरू भएको छ. तपाईँले त्यसमा इनिसिएसन पनि लिनुभएको छ र धेरै मान्छेहरूले इन्ट्रेस्ट पनि गरेको छ. तर मेन कुरा के हो भने लाइक हामी अस्तिदेखि कुरा गर्दाखेरि रिसर्चबाट ट्रान्सलेसन हुनलाई एनएचआरसी र मन्त्रालयको दूरी भनेको इट्स नट लाइक 2 minutes होइन. के कुराले चाहिँ त्यो च्यालेन्ज, त्यो ग्याप वाकिङ डिस्टेन्सले हो कि अरू कुराले हो कि के कुराले त्यो च्यालेन्ज देखाएको छ कि हामीले त्यसलाई ट्रान्सलेट गर्न नसकेको? किनभने वी क्यान बी दि कन्ट्री होइन, लो इन्कम कन्ट्रीले चाहिँ त्यसलाई लिड गर्न सक्ने कुरालाई चाहिँ कसरी उस गरेछ. एन्ड अल्सो सरी टु से बट एडप्टेसन इज लाइक आई कान्ट से. म एउटा कन्ट्रीमा बसिरहेको छु जसले एडप्टेसन मात्र भनिरहेको छ, बट मलाई मिटिगेट गरेर काम छैन. तर मिटिगेसनको लागि पनि हामी कसरी ग्लोबल लेभलमा एडभोकेसी गर्नलाई चुकिरहेछौँ त्यो कुरा पनि भनिदिनु होला. थ्याङ्क यू.
Thank you so much. I'll try to answer in English because this may be relevant for other countries and people too. So first, I'm optimistic people. So I don't see any challenge, you know, because we have conducted the 2 study about the utilization of the research finding in policy and planning. And that 2 studies conducted from NHRC clearly show that if the research findings are of quality with the adequate sample size, means most of the research findings are translated into policy and planning in Nepal. Just one example, climate change. Next example of mental health. Next example of antimicrobial resistance. Next example of non-communicable disease. Like if you see 10 years back, there was not mentioned anything about the NCD in our policy documents. But now the government has clearly mentioned NCD in the National Health Policy. We have a multi-sector NCD prevention and control plan, everything. And from researcher perspective, they want everything to be translated into policy and planning in the written document. That is a wrong concept. Because policy means maybe even a verbal decision or written decisions. So that need to be taken consideration. And usually our research are cross-sectional study. Let's say more than 90%. They are conducted at the municipality level or some ward, and they want to change the national policy. That's the major lacking part from researcher perspective. And next important point that policy making process is not linear. Different factors play the role, like cultural acceptance, social acceptance, economics, how much cost involved, sustainability part. These all need to be considered. For example, let me give one example. We do the RCT trial, randomized controlled trial. The finding will come, published in, let's say, Lancet Journal, a British medical journal, but may not necessarily translate into clinical practice, because normally the clinical trial are led by the medical doctors. They don't consult with the social scientists. They don't consult with the health economists, and sometimes the cost is very high. And that should be the cost effective too, right? So we need to consider the different parameters in policy making process, and if that research fulfill all these criteria, definitely that translate into practice. So the good news is that now I see that Dr. Abhilasha Karki also here, means now in the clinical trial, the community empowerment, community engagement, and multidisciplinary team involvement like social scientists, health economists is increasing. So that's the good sign for our country. Thank you.
Thank you. I think we'll take one more questions after this, and then we'll stop it. Okay, after this you. That will be the last question.
म खिम खड्का, म गण्डकी प्रदेश स्वास्थ्य निर्देशनालयको महानिर्देशकको पदमा कार्यरत छु. डाक्टर सुशील, डाक्टर धिमाल तीनवटै प्रेजेन्टेसन डिटर्मिनेन्टमा छन् र सिन्थेसिस प्रमाण चाहिँ हामीसँग धेरै राम्रो छ. हामी सबै मिलेर, म मन्त्रालयलाई मात्रै भन्दिनँ, सबै मिलेर आउने वर्ष इनिक्विटीको एगेन्स्टमा काम गर्नुपर्छ कि डाक्टर साहब. कुनै 3टा इन्टरभेन्सन लिएर सुरु गरौँ र अर्को वर्षको हाम्रो कन्फरेन्समा यति घट्यो भनेर 3वटा इन्टरभेन्सन हामी मन्त्रालयको तर्फबाट, गण्डकी प्रदेशको तर्फबाट म कोलाबोरेट गरौँला त के गर्ने भन्ने विषयमा हामी कर्मचारी तन्त्रबाट पुगेन भने डाक्टर साहबले एउटा छोटो ब्रिफ बनाएर फेरि संसदमा पनि त्यो पुर्याउनु पर्यो। यति गरौँ डाक्टर साहब, मेरो रिकमेन्डेसन हो। थ्याङ्क यू।
प्लिज यता यता हल्को दाहिनेपट्टि अगाडि प्लिज।
Hello, I have a question with Dr. Prabhakaran. Sir, is there any effect of the climatic change on the cardiovascular diseases, like because of the increase in temperature and because of the global warming and these all? Are there any relations on the cardiovascular diseases? I need that answer, sir.
Right. So data are actually emerging very recently. In fact, we have published just 2 months back, 2 weeks back, the role of heat waves on cardiovascular mortality. One thing which is very clear is that irrespective of the baseline temperature, you might think, cardiovascular mortality will go up in cities which have very high temperature naturally, like going from 40 to 45 degrees or so. But what we have seen is even a city like Shimla, which is considered a resort during summer, if the temperatures go up by more than the 95th or 97th percentile, the mortality goes up. Because we are not geared to even slight increases in temperature. So the clear definition is if temperatures go beyond 45 degrees, you have to kick in a plan to reduce cardiovascular mortality. Second is, if in a given city a temperature goes up by 5 degrees within a short span of 2 to 3 days and persists for a week or so, the mortality goes up. So we need an action plan. In India, they have a heat action plan which kicks in when the temperature goes beyond 40 degrees, and advisories are provided. It's an equity issue because it's the poor who are toiling in the sun who are going to be affected, and there is advice provided to them. There are some innovations which are happening, like making cool roofs as an example, inexpensive cool roofs, and that has actually empirically shown to reduce mortality. But data are very, very preliminary. We need more studies on this area.
Thank you. I think this was a great session and the talks were great. I have a quick question. Who? All right, last lady, we shouldn't exclude. Come on, quick. That would be the last. We're not going to take any more.
Yeah. Hello. My question is to Meghnad sir. As he says that climate changes affect a lot. So I'm from the Sunsari district. So I have seen there lots of people have the heat stroke. So is there any intervention to reduce this climate change effect? Is there any plan for the...
Thank you so much. Actually, we conducted a study in 2018, and that clearly showed there are not any policy and plan to address this heat wave issue in Nepal, right? Though, but the continuous dialogue is going on with the Ministry of Home Affairs, Ministry of Health, and other things. So hopefully, very soon we'll come up with some plan of actions. Thank you.
Thank you. I think that was a great session. I have some questions to Dr. Prabhakaran that I'm going to ask over the break because we ran out of time. We're running beyond schedule. But I would like to thank Dr. Harris, Dr. Prabhakaran, Dr. Dhimal, and Dr. Baral for their great insight, very comprehensive presentations. We had a lot of learning opportunity. And for the audience and the experts that asked questions. With this, I'd like to hand over this microphone to my co-chair. No, I'm going to ask that outside, okay. not here, because I don't want to chew up time. So for the wrap-up comments, please.
Thank you, sir. It was very wonderful session. I think the gap we discussed, the more we discussed regarding policies and their implementation, and the topic I like most were addressed in this session. So I'm very thankful to the speakers. I think we'll conclude this session formally. Thank you so much.
Thank you so much. I thank all the speakers and the chair for chairing this session. I'd like to request everybody to gather here for a photo opportunity. Happy times comes and go, but the memories last forever. Things in, but memories last forever. So let's gather here for a photo opportunity. That was very, very thought-provoking session, first session for the day. We just learned. Hello. So we just learned about the health equity, the hindrance we are facing in attaining health equity. We are heading for a short tea break. हामी यसपछि tea break मा जान्छौं. लगभग 20 मिनट को tea break पछि we'll be joining here in this hall for the next session. Thank you so much. सबैजनालाई धन्यवाद तपाईहरुको uninterrupted attention का लागि. I'd also like to thank Professor Dr. Harris for joining us via online throughout the session. We really appreciate your presence here. With this, we've come to an end of the first session. We are heading for a tea break. Tea break पछि हामी पुनः अर्को सेसन का साथ आउने छौं. Worry without action is just a wasted emotion भन्ने कुरा यो सेसनले हामीलाई छिनाएर गयो. We need to act and let's come back after a short tea break. Thank you.